Well, hello, everyone. My name is Dr. Kathleen Moore. I'm the Deputy Director at the Stevenson Cancer Center in Oklahoma City, and I'm a professor in gynecologic oncology here. And today I'm going to be talking about advancements in standard of care and advancements in the treatment of ovarian cancer, particularly focused on what we call maintenance therapy. So I just like to put this up, although it's always hard to put this up when I'm speaking to our patients and families, but I think you're probably living and are well aware of the challenge with ovarian cancer. Despite a lot of effort, if we start on the left-hand side of this slide, a lot of effort continues to go in for screening for ovarian cancer or for improving early interception and prevention. We just are not there yet. And so most of our patients who present with ovarian cancer present in an advanced stage, stage 3 or 4, because of the failure really of our ability to screen up to this date. Despite that, at least when we talk about tumors that are characterized as high-grade serous or high-grade endometrioid, these tumors can be exquisitely sensitive to chemotherapy. And so with a combination of chemotherapy and radiation, or not radiation, of surgery, we typically end that first therapy with our patients in what we call a very good response, or we might call it no evidence of disease, or some people call it remission. But despite that initial really strong response, by about 3 years, we really expect 70% of these tumors to come back. And this is really where the concept of maintenance in the front line comes in, and I'll take you through that data to see if we can reduce this number and at least delay recurrence, if not prevent it. Because doing one or both of those things will help us improve the percentage of our patients who are alive at 5 years, which right now still sits at about 50%, which is unacceptably low. And so I do think we are starting to move the needle on this, but there's still quite a bit to do. This is just an example of what we call the natural history for a patient with ovarian cancer. And again, many of you are probably living this and know this all too well. But if you start on the left-hand side of the screen, on the y-axis, the vertical axis, this is like the tumor volume or CA-125. And you can see at presentation, both of those will usually be quite high CA-125, and a lot of tumor volume or ascites, sites of disease, et cetera. But with surgery and chemotherapy, we usually can knock that down, and it can stay down for a variable amount of time. For some patients, unfortunately short, but for other patients, a long time until it recurs. And the recurrences over time are characterized somewhat arbitrarily as sensitive or insensitive to platinum. We say platinum sensitive or platinum resistant, meaning basically that if a tumor has recurred more than 6 months from the last exposure to platinum, we term it platinum sensitive. And if it recurs less than 6 months, we term it platinum resistant. Very arbitrary. We could spend an hour talking about that, but that's what we do. And if tumors are classified as platinum sensitive, we tend to retreat with platinum. And that's what you can kind of see here for this particular patient, her first recurrence and second recurrence right here. So this recurrence and this recurrence are both deemed platinum sensitive, and so we retreat with platinum. And again, it works pretty well, but not as well as it did the first time. So we don't come back down to this x-axis, the horizontal axis, as readily as we did with the first therapy. And with each subsequent recurrence, there's sort of more tumor at baseline, and there's a less of a drop. And so it just sort of builds for our patients until such time, that they're having trouble with digestion and bowel obstructions, which is, unfortunately what can happen with ovarian cancer. And this is what we're really striving to prevent. So our focuses are many. There are quite a bit of very large studies ongoing, currently trying to screen, which is the penultimate goal. We are still working on a lot of therapies in the recurrent platinum resistant setting. I'm not going to talk about either of those two today, but they're important. But what we realize is that if we're going to cure more patients, in the front line, we really need to use maintenance to its best effect, and in biomarker selected tumors, and continue to develop regimens to work here. So frontline is our best opportunity to cure. Now I'm going to spend the most time talking about maintenance, but I did want to just touch briefly on the concept of surgery, because I think it's important, and I think it's very important that patients and families be well educated on the importance of surgery, which is a little bit controversial, and this is my talk, and so you're going to get my opinion. But I do think that surgery in the front line is very important if done by a high volume surgeon. And what you can see here on the right, this is called a Kaplan-Meier curve, and I'll be showing these throughout my talk. And basically, how you interpret that is if you start on the kind of upper side up here, it's like 100% of patients, are alive. This is a survival curve. And every time this kind of drops, these are patients, who have died. And so if you look out here at 60 months, okay, that's 5 years, patients who are able to undergo a surgery first, what we call a primary surgery, and that surgery got all the tumor we could see out, their likelihood of being alive at 5 years is almost 70%, as compared to those patients whose tumors were not completely resected, or who get neoadjuvant chemotherapy and an interval surgery. The likelihood of being alive at 5 years is lower. Now, not everybody can get primary surgery, because sometimes the tumors are just too spread and it's just physically impossible to remove everything that we can see without, killing you. So we don't want to do that. So there are cases where neoadjuvant chemotherapy is very appropriate, or in cases where, someone's just too sick, or a huge surgery, might cause such severe complications that they might die. So those are situations where neoadjuvant is appropriate. But we shouldn't be doing neoadjuvant because someone's not seeing a high volume surgeon who has the skill set to remove the surgery. So we really start off on the best foot for chemotherapy. And that's a controversial opinion, but it is mine. In Europe, where I have many friends, and many of us do, they have really codified this. They have made classifications for what being a high volume surgeon means, and institutional qualifications, and they've tried to centralize access to high volume surgeons. Now, countries in Europe are very different than the United States, and the healthcare delivery system is very different, and that's another 1 hour talk. So there are differences, but I think the fact remains that all patients at diagnosis should be evaluated by a high volume surgeon at a large center to make sure that they are fully assessed for whether or not they should undergo a primary cytoreductive attempt. Last thing I'm going to say about that is there's a gigantic study that's finished. We're waiting on the results, called the TRUST study, that randomized patients agreed to be randomized to neoadjuvant chemotherapy and interval surgery versus primary surgery. But in order to participate in the study as a investigator, you had to be a high volume surgeon. So it removed the bias of all the other studies that have been done where you had lower volume surgeons where maybe surgical outcomes aren't as good. So this was only done by high volume surgeons really asking that question. So, if that results out and the patients who got primary surgery do better, then this is a no-brainer. We're going to have to do this in the US. If it comes out sort of equivalent, then I'm going to have to change my bias, which I will do. And I will update this talk with an updated opinion on the importance of primary cytoreduction. But as of today, I think it's incredibly important, and it's important for patients to advocate and make sure that they are seen by a high volume surgeon. Why? Why am I saying this? It kind of seems obvious. If you cut it out, it will do well. And patients will say, well, if you could cut out 90% of it, won't I do better than if you don't cut out any of it? And the reality is probably not. It's really all or none. If we can get everything we see out, that's where we get to something called minimal residual disease. You can see that in the middle here. And in those situations where you cut everything out and then you give chemo, there's always tumor cells left. It's just true, but very few. And those tumor cells may be very similar to one another. Like they haven't change. They haven't started growing and changing and getting what we call heterogeneous. And so if you bring in, especially a biomarker targeted maintenance, like a PARP inhibitor in appropriate patients, the theory is that you can mop up those residual cells and cure. Even in settings where you remove 90% of the tumor, that's still like, there's still millions of cells left. And so the opportunity for those cells to grow and change and get more heterogeneous kind of makes the likelihood of cure. It doesn't mean that maintenance won't help, probably will, but makes the likelihood of cure less. And so the more we can do to surgically and chemically cytoreduce down to this minimal residual disease, the better the chance we have of curing in the front line, which is our goal until we can screen and prevent. So we talk about maintenance. It's been about a 20+ year journey. When I was training in the early 2000s and early faculty, we did paclitaxel and carboplatin for 6 to 8 cycles, and then we stopped. And we closely monitored our patients and watched for recurrences because that's all we had. In about 2010, 2011, the bevacizumab era, you know, this is Avastin, came into play, and I'll show you that data in the next slide. And that was, it was and is and remains an important medication for our patients. Did it cure more patients? No. Did it help patients not progress for longer? Yes. So there are benefits to it, but it wasn't a home run. We've got signals of potentially a home run in 2018 with the first presentation, and this is frontline maintenance of a PARP inhibitor in the frontline with the publication of SOLO-1, and I'll show you that. And that was just in BRCA mutated tumors. And then after that, in 2019 onward, we saw PARP inhibitors and the benefit of PARP inhibitors in all comers, but with some caveats that I'll take you through. So let's just review the bevacizumab or Avastin data first. There were a lot of studies. These are just 2 and that we talk about because they're the 2 original ones. One was done in the United States, one was done in Europe, and they're pretty similar. They asked patients to participate in a clinical trial where they were randomized to get chemotherapy with paclitaxel and carboplatin alone, standard of care, or the same chemotherapy plus Avastin, and then Avastin maintenance for about a year. And the year kind of was a guess, just that's how it was designed. There wasn't a lot of science behind it. So there are some differences between the 2 studies, but mostly they were the same. And the results were very much the same. So again, these are those Kaplan-Meier curves I was telling you about before, except these Kaplan-Meier curves are for progression-free survival, not overall survival. So again, if you start at the upper point on either of these, like right up here, this is 100% of patients at the beginning of the study had not progressed. And as you follow along over time, time is on the horizontal axis, you can see that patients are progressing. And when you are looking at these, you're looking for a big space between the curves to tell you that a medicine is working better or sometimes worse than the control arm. So the control arm is chemo alone, and then this is chemo plus Avastin and Avastin maintenance. So you can see there's a relatively, I would say this is a big space, but it's a big enough space that you recognize there's a space there. You don't have to squint to see a space in between. So that usually tells you that it's at least statistically significant and probably clinically relevant. So for when you add Avastin to chemotherapy and then follow it as maintenance for about a year, and there's no benefit for doing it longer, so we stop at a year, you get about a 30-ish, 20 to 30% reduction in the risk of progression over that time period. So that's sort of how we talk about risk reduction. So it's not huge, but it also is not nothing. And so if you can prolong the time to progression with a medication that doesn't make patients feel terrible, that's something that I tend to talk to patients about. Some patients want it, some patients don't, because there are side effects, mainly hypertension and joint pain. And some of my patients want no part of that. And other patients are all on board and they want everything that's in their armamentarium. So this isn't a home run, it's like a base hit if you like sports. but it is an important medication for us to consider. But as I said, in 2018, the world changed with PARP inhibitors. So PARP, what is PARP? PARP stands for poly-ADP ribose polymerase, which you don't have to remember, you can just say PARP. But it's a protein. So PARP is a protein that fixes DNA. When tumors are replicating, they're doing it really fast. They make tons of mistakes. It's something called replication stress. Like they're trying to grow so quickly, they're making a lot of mistakes, and those mistakes need to be repaired. And our normal cells have these very elegant surveillance mechanisms for identifying DNA damage and bringing in all these proteins to fix it before the cell completes division. Cancer cells don't have all those components, and they struggle to fix their DNA. And so it's a point of vulnerability for some cancer cells that they're struggling to keep up and fix the DNA and to keep replicating. And so if we take out a key protein in how they're fixing their DNA, they kind of collapse. And so that's what PARP is. So PARP is a key protein in fixing DNA. In ovary cancer, about half of the ovary cancers have an inherent vulnerability to how they fix their DNA, mostly from BRCA. So if a tumor is driven by a BRCA mutation, BRCA is a gene that encodes a protein called BRCA that fixes double-strand breaks. So it's a really important, also really important protein in fixing DNA. So if there's a BRCA mutation, the BRCA protein is gone. And so how does the tumor fix its double-strand breaks, which happen frequently in replication? Well, it needs PARP. And if we inhibit PARP in a tumor that's already lost BRCA, and you can see this over here, that cell will die. So for a PARP inhibitor to work, there has to be some inherent vulnerability in that tumor, BRCA mutations, and there's many other less common mechanisms by which that tumor's struggling to fix its DNA, and then I take away its PARP and it dies. So that's how PARPs work. The unfortunate truth is that about 40, maybe even 50% of ovary cancers don't have that inherent vulnerability. They're really good at fixing their DNA, which makes those cancer cells able to fix the DNA damage that some of our chemotherapies cause. And they can fix them and not die, and that leads to resistance. So that's one of our biggest challenges in ovary cancer, is kind of overcoming those cells that are just not smarter than PARP inhibitor, but they just have mechanisms in place that allow them to kind of live through whatever we throw at them. So when we think about PARP inhibitors, this isn't even a complete list. We have studied them, every PARP inhibitor in every setting in ovarian cancer, both as maintenance, which means we've induced a response with chemo, and then we're using a PARP inhibitor to try to maintain that response. That's what you see on the left-hand side of the slide. All the studies have been done. And then for a while, we were thinking, well, maybe we could use a PARP inhibitor instead of chemo, because that would be nicer. You could just use a pill instead of infused chemo, and maybe patients would like that better. And so we did a lot of studies as treatment, and you can see that on the right-hand side. And I'll touch on those at the end of my talk. But I'm mostly going to focus on frontline maintenance. So when we think about frontline maintenance, the first big study that came out with PARP inhibitor was called SOLO-1. And I'm going to show you the schema for SOLO-1, meaning the study design, in a sec. But I wanted to make a couple of points first, things we've learned along the way. SOLO-1 was a clinical trial that asked patients who had BRCA mutations to participate. And they had first newly diagnosed ovary cancer, and they had their chemo, and they were in response. And then the standard of care at that time, this was 2013, was placebo, was nothing, not placebo, just maintenance, your observation. We just watched versus 2 years of olaparib, and which is a PARP inhibitor, Lynparza. And when we launched the study, many physicians said, well, that's crazy, because patients who have BRCA mutations and BRCA mutation associated ovarian cancer, they're all cured. they're all cured and you're over treating them. And, I have all these patients in my practice and they're just walking around just fine after chemo. And so why are you doing this? And so there's a real bias. And the truth is, and this is just, I'm always going to be truthful with patients, is we remember the patients who are alive. So I know all of my patients with BRCA who've been alive 10 years. I love seeing them. I remember them. But it's not that I've forgotten all of my patients who have died, but they're not front of mind. So our biases are really set by what's in front of us. And then we do clinical trials, we realize the truth. And the truth is this slide. So this is the control arm from SOLO 1. So all of these patients who volunteered for this clinical trial and were randomized to the placebo arm, which honestly feels unethical. Now I know what I know, but at the time we didn't. They all had BRCA. Most of them were stage 3. They had good surgeries. They were very good prognosis. But when you don't use maintenance, they recur very quickly. 20% of them had recurred within 6 months of finishing their platinum. And over half had recurred by about 4 years. And I'll show you the updated data. And so there are some who are cured. Yes, there are. And I'll show you that in a minute too. We just can't tell who they are. Who doesn't need a PARP? I cannot tell you who those patients are right now. So we are over-treating about 20%. But even BRCA-associated ovarian cancer is incredibly high risk for recurrence with chemo alone, which I think justifies maintenance. And this is something that took a prospective clinical trial really to prove to people. The second sort of bias related to that was physicians would say, well, I think you're over-treating all those patients with BRCA, and I'm just going to wait and use a PARP inhibitor when they recur. If they recur, I'm going to use it then because it works just as well. And so on the left-hand side, I'm showing you SOLO 1, which is the frontline maintenance study, which I'm going to talk a lot about in a minute. And on the right-hand side, I'm showing you SOLO 2, which is a study that was done in patients whose cancer had come back and they were deemed sensitive to platinum, and they got platinum again, carboplatin plus whatever, and had responded. And then they were randomized to PARP placebo, just like frontline. And the risk reduction for progression in both of these was the same, about a 70-ish% reduction. That's huge. 70% reduction in the hazard progression in both of these studies. And so people said, well, I'm just going to wait, and if I need it, I'll use it then. But that 30% risk reduction means very different things in a frontline setting versus a recurrent setting. In both settings, PARP in BRCA tumors is incredibly active, no question. But if you look on the right-hand side, you gain about 14 months of time, of progression-free time with use of PARP inhibitor, Lynparza here versus placebo. If you compare that to the frontline, we gain almost 4 years and the potential for cure. And so even though it's in both settings, the 70% reduction in the risk of progression, what that means and the magnitude of the benefit is vastly different. The best place to use a PARP is in the frontline, and for a time-limited amount of time, which I'll show you in a minute. So those are 2 myths that we really had to overcome in the field of maintenance to best serve our patients. And so this is just a replay of the slide I showed you before. We've entered the PARP era in 2018 with SOLO 1, and then it's just taken off, from there with a lot of different PARP inhibitors and different populations that I'll take you through kind of quickly. But I'm going to spend the most time on a couple studies, SOLO 1 being the first one. I've already told you the design. Advanced stage, everyone had BRCA, everyone got chemo and a surgery and was in response. And then randomized 2-to-1 to 2 years of either olaparib, which is Lynparza, or placebo, and we were looking for an improvement in the time to progression. And so that's what we saw. And so remember I told you when you look at a Kaplan-Meier curve, you want to look at the space. How big is the space between the curves? So this is an enormous space between the curves, and represents a 70% reduction in the risk of progression. And I will note that patients stopped treating at 2 years. So you see that 2-year treatment cap. So once you're out here, patients on both arms are not getting anything anymore. We're just following them. And at our first presentation back in 2018, we had 3 years of follow-up, and we had 60% of patients versus 27% of patients progression-free at 3 years. So did that hold? Yes. So here's 5 years. So the curves are pretty parallel here and pretty flat. So you don't see it, if you look back here, see the curves are dropping. So these are patients who are recurring, and these are tumors that are biologically, we need to understand better. But then it starts to flatten, meaning the event rate, like the number of patients who are, the farther out you get, the number of patients who are having recurrences, the rate drops a lot. Like our patients are just kind of cruising along. And at 5 years, it's 48 versus 21% progression free, which is a substantial and sustained difference. Now, this doesn't come without cost, and the cost is nausea. Frequent, low grade, but annoying when you're on a PARP inhibitor. And so we do have to be very aggressive with mitigation strategies so that our patients, you all, feel okay while you're taking this medicine or any PARP inhibitor for 2 years. Because it's very common to have low-grade nausea and low-grade fatigue, every day, because you're taking a medicine every single day. And so we, as physicians, we go, well, this is a manageable safety profile, but it's manageable for us, but is it really manageable for you? And I think that's really the point, is that these medicines are amazing, but they do come at a cost, and we really have to pay attention to how much toxicity we're causing a patient in order to gain. Now, if we're curing more patients, I think the allowances for toxicity is higher, but nevertheless, quality of life remains incredibly important. So that's SOLO. The next study I wanted to show you was PAOLA, because this brings a lot more of you into the picture if you don't have a BRCA mutation. PAOLA was done outside the United States, and it said, well, in many parts of Europe, they can only use bevacizumab or Avastin in the front line. Like in the US, we can use it whenever we want. Some parts you can use it frontline, or you can never use it. And so they're like, we don't want to give up our bevacizumab, so we just want to add olaparib to it. And this study was done before we knew the results of SOLO-1, I will tell you, because we would never randomize a patient ever in the future with BRCA to not get a PARP. But this is before we knew SOLO, and so it was done here. And this was all comers, so BRCA, non-BRCA. Everyone that could come on stage 3 and 4, high-grade serous, high-grade endometrioid ovary cancer, who had received chemo plus bevacizumab, and then they were randomized 2-to-1 to get olaparib added to the bevacizumab, or just continue with the bevacizumab for the same amount of time. 2 years of olaparib, 1 year of bevacizumab, just like the prior labels. And the outcome was progression-free survival, which you can see here. So olaparib, bevacizumab versus bevacizumab in all comers, that's a big space between those two curves. And that tells you that olaparib bevacizumab arm is performing much better than bevacizumab alone. And bevacizumab is not a bad drug. It has activity. And so now you've built on that. You're not versus placebo, you're versus an active drug with about a 40% reduction in for the risk of progression in all comers now, BRCA and non-BRCA. And so this is where the biomarkers become important. So we have a biomarker that we call HRD, or homologous recombination deficiency. So that means that a tumor struggles to fix its double-strand breaks. That's what HRD means. So a BRCA tumor is automatically going to be classified as HRD. But then there's other reasons a tumor will struggle to fix its double-strand breaks that are not related to a BRCA mutation. And they'll also be classified as HRD by these tests that we send on your tumor now. So in clinical trials, we are categorizing tumors in this way. So in PAOLA, you can see on the left, these are the HRD positive tumors, the patients with HRD positive tumors who participated in PAOLA. So this includes BRCA. They had, it looks just like SOLO, about a 70% reduction in the risk of progression with the addition of olaparib to bevacizumab versus bevacizumab alone. On the right-hand side, you can see only the BRCA patients with BRCA tumors pulled out, and it's about the same. But unfortunately, at least in this study, for patients with tumors that are not homologous recombination deficient by a test that we send, not a functional test, it's just like an assay, a yes/no question test. So it's good, but not great. But irrespective, the tumors that were classified as HRD test negative, the addition of olaparib to bevacizumab did not improve progression over bevacizumab alone, which is why in the United States, we can only use this regimen in patients whose tumors are classified as homologous recombination deficient. And for those tumors that are homologous recombination deficiency test negative, we cannot use this regimen, but I'll tell you what we can do in a moment. We can use bev alone, of course, but there are other things. There are really no new safety signals here, so I'll skip through this, but you can pause the video if you want to just look at this a little more carefully. Still common, but low-grade nausea and vomiting. And then here we have the addition of hypertension because of the bevacizumab. And this is the amount of hypertension we see with bevacizumab alone. It's about 50% of patients will have some increase in their blood pressure, about 20% to a point where you're having to adjust medications. And that's what we think, 20% high enough grade that I have to give you a medicine for your blood pressure, but you do see some drift upward in almost half of patients. But this is the same as we see with either agent alone, the same toxicity. Just here, now that you're using both, you'll see both sorts of toxicity. So I've talked a lot about olaparib. In order just to be fair and balanced, I want to talk about niraparib, which is another PARP. It's also a good PARP. And it ran a different study called the PRIMA study. This was also all comers. So it wasn't just BRCA. And they really looked at patients who came in with very high risk cancers, so stage 4, or tumors that couldn't have a primary surgery. So they got neoadjuvant and then an interval surgery. So these were very different types of stages than were included in the other 2 clinical trials. So that was the inclusion. They still had to all respond to their carboplatin paclitaxel. They had to be in a response. And then they were randomized 2-to-1 to get a PARP inhibitor, niraparib, you may know this as Zejula, or placebo. And the primary endpoint was progression-free survival. And this was also positive. So you can see again, you can see a big space. This is the all-comer group, big space between the PARP versus the placebo arm that's been maintained over time. Now, niraparib also has the same nausea that we see with olaparib, but it also has a little bit more impact on platelets and white count. So we do have to watch lab counts more carefully when we're starting niraparib than olaparib until you're on a stable dose, and then we can go to just every cycle labs. But that is one nuance of niraparib, is it's a little bit harder on the platelets than is olaparib. If we look at the PRIMA study in that HRD positive tumor group, now patients aren't HRD, their tumors are, so I need to change the slide. But you can see the same thing. It's an even bigger space between the 2 curves, and it's about a 50% reduction in the risk of progression with niraparib versus placebo. Now, different than Paula, here in the tumors that are HRD test negative, remember in Paula, there was no difference between bevacizumab and bevacizumab PARP. Here, there is a difference between placebo and PARP. So you can already see the differences. If you're not going to use bevacizumab, there is some benefit to a PARP inhibitor in this space. It's modest. It's about a 35% reduction in the risk of progression. So I would say a modest benefit, but it is a benefit, and it is something to consider with your physician if your tumor is HRD test negative. So that all those endpoints I just showed you were based on improving the time to progression. The more important question is, are we helping patients live longer? Like, are we changing overall survival? And we do have early data from this. So I'm going to show you Paula first. Remember, this was olaparib bevacizumab versus bevacizumab. This is the overall survival for the all-comer group, all biomarkers. And it's about the same. There's maybe a little numerical improvement for olaparib bevacizumab over bevacizumab, but not statistically significant. But there's certainly not harm, so that's encouraging. But if you look at the biomarker groups, you do see a little bit of a different story. On the left, you see the BRCA, the HRD test positive tumors, including BRCA, but not all BRCA. And that's a bigger difference, 65% versus 48% alive at 5 years. So that's a statistically relevant improvement in overall survival at 5 years with the addition of olaparib to bevacizumab in an HRD positive group. On the right-hand side, you see the HRD test negative, where it didn't help progression-free survival, and so you wouldn't expect it to impact overall survival. And then here, just looking at the HRD tumors, on the left-hand side, you see the BRCA tumors further pulled out. These are called subset analyses, and so they're smaller numbers. You have to take them with a little grain of salt, but they're consistent. So at 5 years, 73 versus 53% of patients still alive with PARP Bev versus Bev. So clearly, PARP inhibitors are key for patients with BRCA. For patients whose tumors are HRD positive, but they don't have BRCA, so they're HRD because of some other mechanism, the benefit for OS is less, but it's still there, about 55 versus 44% of patients alive at 5 years. So a more modest improvement, but still a trend in the right direction that, at least until I have something better, makes me want to use PARP in this space. This is I think one of the most important points though, because overall survival is good. Yes, we want to be alive, but I want you to be alive without cancer. If you're alive, but you've been on 8 things to keep you alive, again, I'm glad that we're keeping patients alive for longer, but I would like to cure you in the front line. And so this is sort of the surrogate for looking at that. This is 5-year progression-free survival on Paula in the HRD positive tumors. It's 46 versus 19%. So there are patients who are cured without PARP, and it's right about 20%. You can see that, but you over double that with addition of PARP. So at 5 years, 46% of patients who got olaparib bevacizumab have not recurred, and they have not received any sort of therapy for, 3 years, which is interesting, encouraging. I'm going to show you the same thing from SOLO-1, which is all BRCA mutated tumors. So this is the control arm at 7 years. We have 46% of patients alive, which is pretty good, except we have 67% of patients alive if they got a PARP. So significantly higher number of patients alive at 7 years. What about progression-free survival at 7 years? Well, this is it. So at 7 years, we have 45% of patients who have never recurred, versus 20% who didn't get a PARP. So again, it's right about 20% in these HRD positive tumors who don't need a PARP, and it would be nice to know who they are so we could de-escalate therapy, but I cannot tell who those patients are, so we are going to over-treat you to try and bump you into that 45% who have the potential of being cured. So this is the first signal of cure in these 2 studies we've ever seen in ovary cancer, and sort of opens the door that this is a possibility in more patients than the 20% that has historically been cured. So this is exciting. I'm going to skip through this a little bit in the interest of time, but I think the slides will be up here. We used to use PARPs as maintenance in the platinum sensitive setting, and I told you about SOLO-2, and that remains an active indication. If a patient with BRCA has not received PARP in the front line, which they all should, but if they for some reason didn't and they have a platinum sensitive recurrence, they should get a PARP. Lots and lots of studies done in this space, because this is the first place we developed. All of them had progression-free survival endpoints, and they were all very positive, which is why we had indications to use PARP maintenance following platinum sensitive recurrence and following that 2nd or 3rd platinum for all of these PARP inhibitors. But then the overall survival data started to emerge. So this is 2 of the studies, and these are just patients with BRCA mutations, and the overall survival looks no better, no worse. So that wasn't a big red flag. This was the big red flag, though, in patients who did not have BRCA, so BRCA wild type, who got a PARP in the platinum sensitive maintenance setting, where we treat indefinitely. You treat until progression, not just for 2 years. Here we saw signals that overall survival was impacted in a negative way, with a 20 to 30% reduction in overall survival. And that was very concerning and led the FDA to retract the indications for PARP inhibitor in the platinum-sensitive recurrent setting for everyone other than BRCA because of this worry. And it wasn't just maintenance. Remember, I told you we tried to do PARP as instead of chemo in BRCA. We used PARP instead of chemo in the recurrent setting, like second line, like third line, fourth line, fifth line. And progression-free survival in all of those studies looked very good, but overall survival did not. And so we saw the same trend in these 2 studies, that overall survival appeared to be negatively impacted. And so all approvals for PARP in the recurrent treatment setting were also retracted. And so again, just emphasizing the point that we need to be using PARP, in the front line. The reasons why overall survival looks negative are complicated. It may just be the statistical designs of the studies. They were underpowered. There's missing follow-up. There were global studies where access to therapies after this line of therapy are limited. And so, if you're in the US and I can give you 3 more things and you're in Ukraine, which was this really happened. And they, of course, could get nothing else after participating in a trial because it was a war zone. That's going to affect your overall survival right there because you had people that had different access to subsequent lines of therapy. But there's also biologic considerations that using PARP inhibitors in the recurrent setting until progression may induce resistances that make responses to next lines of therapy less. So we're still working on these issues, but I just wanted to mention why we no longer use PARP in the recurrent setting, really. And it's because the most benefits in the front line, we're using it in a time-limited way, so we're not inducing resistances, we hope, and we're not seeing those overall survival detriments. But that's the current state of affairs at this point. I think I will stop just because I could go on for 2 more hours, but it's a limited, we all have a limited attention span. But I thank you for your attention.